My guest today is Dr. Andrew Lerman, a double board-certified neurologist and epileptologist, and the founder and medical director of Grove Neurology in Miami, Florida. Dr. Lerman completed his neurology residency at the University of Miami, Jackson Memorial Hospital, followed by a fellowship in epilepsy and clinical neurophysiology at NYU Langone Medical Center. As a principal investigator, he had led more than 35 clinical trials investigating emerging therapeutics for Parkinson's, Alzheimer's, and other neurodegenerative disorders. Beyond cutting-edge medicine, Dr. Lerman is a strong believer in lifestyle modification, including fitness and nutrition, as essential components of neurological health. He is also a great advocate of Pilates for neurorehabilitation. In this conversation, we explore what modern science tells us about Parkinson's disease progression, the power of early diagnosis, and why movement and exercise may be among the most potent interventions available. We discuss how to counsel patients with hope rather than fear, the role of community and family support, and the emerging research suggesting that staying active can tap into our brain's own dopamine reserves. Welcome to the Live Aligned podcast. I'm Dr. Brent, a doctor of physical therapy, professor, founder of Polestar Pilates, and pathokinesiologist. For over 35 years, I've been fascinated by the dynamic relationship between movement and pathology. On this podcast, I'll host special guests and friends who are making meaningful contributions to help us live aligned and be kind. Hiking, golfing, running a marathon, or playing with your family, what activity do you want to improve this year? Simply changing your center of gravity can improve your ability to jump or to run. Learning to listen to your internal feedback can drastically improve your game and reduce risk of injury. These are examples of movement integration, which is the overarching principle of movement, where breath, mobility, alignment, and control are integrated to optimize your performance. At Polestar Pilates, students are taught the science of movement, how to assess and design the best movement interventions for their clients. Are you ready to move? Find a Polestar Pilates graduate near you. Go to the Polestar Pilates website, click on Find Your Graduate, and search for a professional in your area. If you're ready to begin your own training, go to the Polestar Pilates website, choose your course, and use the code Dr. Brent. The code is DRBRENT to receive 10% off your tuition. And now, my conversation with Dr. Andrew Lerman.
Yeah, so thanks for having me on. It's a great opportunity to educate, the patients out there that are interested, family members, and really dive into Parkinson's disease because, as you said, it seems like everybody knows somebody who has Parkinson's disease, a family member, a friend, a colleague. In the information age, there's a lot of searching the web and a lot of videos out there, and people are looking at themselves, and I get a lot of consultations from younger folks these days too. Hey, I have a tremor, or I started to notice tremor or rigidity. I saw something online that was suspicious and made me come in today, or have a father or family member with Parkinson's disease. What is my risk, and how do I prevent this from happening? So There's a nice shift now with more information. Obviously, with more information, there comes more fear and anxiety, as we both know, but earlier diagnosis and a shift in the paradigm in prevention, and which I love. That's really something that I try to integrate from the beginning of my practice, but even more so in recent years, identifying the disease early, educating patients early, and then giving recommendations on preventative tactics. And you know that very well.
And I love that area. I think this is where, with the age of knowledge at our fingertips, getting correct knowledge and getting it sooner and being able to act upon it sooner. Like if you understand that there's some things you could do to prevent progression or to not prevent but slow it down, if there's things you could do to identify earlier, then this is going to be true with any pathology that you ever talk about, that the earlier we get a hold of it, the better the outcomes are, even with some of these really bad diagnoses that are out there.
Yeah. So patients come in, often quite fearful at various ages, anywhere from in their 40s, 50s to their 80s with, tremor or, I've noticed my family members slowing down, changes in speech, slowing of speech, less, kind of demonstrative with their affect. Or shuffling gait is one that is very common. A family member, a daughter or son notices this in their family member. So there's a lot of kind of fear coming into the initial consultation. Certainly after the initial diagnostics are sent, what did you find? What biomarkers did you find that were or didn't find that are suggestive of the illness? And is this Parkinson's or is this something more like benign? So the discussion is just that from the beginning. Like we see these findings on your physical exam, which is always the gold standard of diagnosis. And we hypothesize and then we send work up to rule out or to rule in the disease. Now we have the luxury of having, DAT scans. We have MRI, obviously, that does not diagnose Parkinson's, but rules out other pathologies and neurodegenerative diseases, which we can get into. But just off the top of my head, and normal pressure hydrocephalus and PSP and Parkinson's-like syndromes. Right. And then DAT scans to tell us, or to hone in on it as well. We have skin biopsies, we have CSF analysis and labs now too. So it's changed from just a clinical diagnosis to having some objective supportive data to counsel patients with and to give them comfort that there's not just one person evaluating you and telling you this is what it is based on your symptoms.
And we certainly saw that in the older days where, sometimes even misdiagnosis or things that were, people living with some of these signs and symptoms in their physical manifestation, but they really were not progressing the way, they might have continued to have a tremor or maybe even a little bit of some compromised gait, but we didn't see the progression of the disease. In others, we saw just the opposite. So I do think it's nice to be able to have more succinct and accurate diagnostic data that supports that and that sort of is accepted across the table. But the other question I was going to have in this early stage is I guess the fluctuation or the differences even with the diagnosis. So Andrew, somebody comes to you, they have some of the early signs and symptoms, their markers test positive. Talk a little bit about the diversity of that pathway that person might be on, because we've seen people that progress pretty quickly, but they live a long time. And we've seen other people that, progress slowly and have a very high quality of life for many, many years before they feel like they're being compromised in their ability to participate in life.
Yeah. So I think the heterogeneity within the disease and within neurodegenerative disease in general has been a difficult topic for patients because of counseling and what to expect. So like, how many years do I have of good quality life left is a question that I get. And to revert back to your last question, the fear, the initial diagnosis, all the questions and question marks that are there initially because of the heterogeneity of the disease, being able to counsel patients has been a limiting factor for us on our side, from the neurology side, from therapy, from all the caretaker perspective. And it's also been difficult to study these patients in clinical settings, like in clinical research, newer and therapeutics, even in studies that involved certain therapy interventions. Pilates being one, the LVST. How do you know what somebody's trajectory would have been without the treatment? And we're seeing that in the disease-modifying world right now, both in Parkinson's and in Alzheimer's. So I get that question all the time.
Right.
But to really answer your question, I'm a big believer that there is genetics involved. There is a larger contribution from environment and from baseline health markers, physical fitness, vascular health, inflammatory health, and how that the individual navigates all of those things is really has a major impact on the progression.
It's funny you say that. I was just looking at some research in preparation for today, just is from the movement science world as it pertains to Parkinson's disease. And what I haven't seen is the literature now that's very supportive of high-intensity training early on in Parkinson's disease. I always think of it as, you'd mentioned, Pilates, Tai Chi, rock steady boxing, things, dancing, tango. I mean, these are all things that have been shown to slow the progression or the need to increase medication with patients with Parkinson's disease. But I was really impressed with a couple studies I saw looking at really getting their vascular health up, and being able to, I guess, and we're seeing more and more of this, the effect it has hormonally, neurologically, cardiopulmonary, of just overall general health, and that people that are able to participate in a more aggressive cardiovascular exercise are actually showing really good signs as well of slowing down progression and being able to maintain a better quality of life. Movement that is going to, preserve the integrity of the central nervous system. But I was impressed with that. And I see it more and more with different diagnoses now too, not just neurological ones.
Yeah, if you do a deep dive into both the prevention data and also in disease progression prevention data, there's vast amounts of information out there for both. And there's been many randomized controlled trials and meta-analyses to support that if rigorous exercise does have a major impact on prevention, of these neurodegenerative diseases, Parkinson's being way up there. Studies dating back to 2010 and 2016, one comes to mind, like a lifetime activity case control study showing a much lower, like up to 50% lower PD risk in patients that sustained regular exercise regimens of moderate intensity quite frequently throughout the week. In patients like over 65, I think was the cohort. So just looking at prevention data is super interesting. And then, once you're diagnosed, intervening with high intensity resistance training, Pilates, there's actually a lot of Pilates studies, and this podcast, it kind of pushed me to go look back at them, but was aware of these types of interventions because I recommend them daily. I find that, aerobic exercise, resistance training, and then, core and balance, if you can hit that triad in the therapy world and have a motivated patient, you can really make huge impact on patients' outcome progression.
I don't know if you remember this or not, but when we were in Coral Gables, we did a 10-year program. It was just a fitness program that one of the Parkinson's support groups had come to us from, and we made it so that they could come and do Pilates twice a week in a group setting. And we went for 10 years. We actually made a documentary video about it that's on YouTube for anybody that's listening. And unfortunately, we did not run it as a study. We just did it as almost more like a service project in the community. And these were all people coming to do health promotion kind of activities. They were not under my treatment as a physical therapist. We just donated the intervention and had our therapists conducting the group classes. And I do think that the group classes had something to do with it as well. And when they had come in with their kazoos and birthdays, and it was pretty fun. But what we saw in the comment that most of them made independently of each other on the interview was that they didn't have to increase their medication regiment for years. And when they knew other people that were obviously dealing with Parkinson's disease in their community that were not participating in these group activities and movement activities and music activities and drama, they really had an incredible support group for these years, had such a better quality of life. And that was very encouraging to me to think of a disease that I was raised to believe in our profession, is there's no cure for it. There's no, it's going to progress and it's going to be very frustrating, and the medicine will become so strong that now they have other types of movement disorders and dyskinesias. And that was my experience coming into that. And it completely changed my outlook and perspective on many of these neurological pathologies. I mean, I think you know that the joke in neurology was diagnose adios, but it's not that way anymore. And there's so many things that are happening in neurology that are just major advances. I'd love to go back for a second, Andrew, and start with, let's just describe what are some of the key signs and symptoms that would motivate somebody early on to go get attention paid to it, to come see somebody like you and to be evaluated.
Yeah, so the genetic, the family member question comes up a lot. And while there are forms of the illness that are highly genetic and can be passed on and gene related, that's a very small portion of the patients that we see that present with symptoms. And most of the time, patients will either notice a tremor. A tremor is it's a positive kind of phenomenon. So you can notice it yourself or others notice it. So, family member, wives, husband, wife, usually one will notice the other. There's a phenomenon within movement disorder where patients don't recognize their own illness or their tremor or their rigidity or their walking problems. So it's usually a lot of the times noticed by someone else, maybe a physical therapist even. Hey, I was referred because I'm having gait instability and I think it was my knee, but the therapist notes that they're having a shuffling magnetic type of gait that's suspicious, and they see people all the time. So they're trained professionals. So I see it a lot where someone in the care delivery field will notice it. But things that patients report and usually prompt initial visits are tremor at rest or postural inaction tremor, which means that when you're using your hand to eat, drink, use a spoon, write, you will notice a tremor. Handwriting changes. So, the quote of "I can't sign my checks like I used to," or people are noticing that I can't write as clearly anymore, or there's the entity of micrographia, which is my handwriting has become quite small, which is, a sign of Parkinsonism in cases. And then, other things like affect, blunted affect, maybe what we call hypophonia, which is low voice or slow voice. So the rhythm of your speech could change as well and become quite monotone. So some people who have a professor who started to notice that when he was giving his classes, he wasn't projecting as easily as he was and not intonating, and it didn't seem to his students that he was as animated. And then, slowness of movement as well, slowness of walking and rigidity. Sometimes you can even present with pain. We see a lot of patients presenting with cervical dystonia and rigidity, lower back pain. As you know, a lot of our patients have like hunched posture, so they end up with this kind of severe type of SI joint, lower back pain. And so those are the kind of most common symptoms. There's a lot of talk in the field now too about non-motor symptoms of Parkinson's and anxiety, mood changes, depressive symptoms. All of that is starting to, kind of emerge.
Which I think is great when it can come out and people can understand, it's like when you look at the whole person. Another very important part that we look at here is, I remember having somebody that was in our church that was incredibly dynamic, and when they were spiritual and connected with everybody, and, later on as the disease progressed, you could see that, he had, and he was trying to express it. I remember consulting with him a little bit before he passed away, but it was like the frustration of not being able to express what he is feeling, the depression, the lack of motivation that he was feeling at the later stages of life. And he was in his late 80s when he passed. And I think that's an important thing to understand is most of these individuals are living a pretty full life. It's just the quality of life that we're so interested in preserving. You mentioned one thing, and I wanted to have clarification on it. A lot of times, even inside the profession, I'm embarrassed to say physical therapy, there's some confusion between rigidity and spasticity. And if you could just clarify, when we see a patient or a client or a family member that is struggling with rigidity, how might that look different than, say, spasticity?
Yeah, so rigidity will usually present more diffusely, and without history that would kind of predispose someone to spasticity. We typically will see with spinal cord injury, brain injury, and could involve like painful spasms, also some limited range of motion across joints, although dystonia will present like that as well. But typically when we speak of spasticity, we're speaking of upper motor neuron or central nervous system injury. Rigidity will involve both, extensors and flexors at the same time as well.
Like co-contractions or...
Co-contraction, all over the body as well, although you can have focal dystonia, which presents with rigidity as opposed to spasticity. But usually the counteracting muscles are both involved with rigidity. But you also mentioned earlier something that I wanted to also not forget, which was your anecdote about the people who would come and do the 2 days a week community exercise programs that would prevent progression. And then it's super important. And the community, I always tell my patients, like, this is a team effort, and the community coming together to exercise and do these types of exercise programs that you noticed, many years ago, way before this started to come out and become a thing in our field, and that even the doctors started recommending, you were noticing these things. And since that time, there has been randomized controlled trials on exercise interventions or certain types of interventions from the therapy side that will prevent progression of the disease. So tying it back to the fear and anxiety surrounding early diagnosis, I'm a true believer that we can modulate this disease in many ways. Early diagnosis is I think, key and paramount. And then after diagnosis, intervening with Tai Chi and with high intensity aerobic exercise. And there's a study, that the Parkinson in Shape study, there's a randomized controlled study as well. And there's an ongoing trial right now called the Sparks program, which is ongoing with exercise interventions for prevention of progression and also evaluating need for escalation in medication management. And we're seeing that what you saw in those patients that you treated, we're seeing that they need less dopaminergic support and escalation in their doses. And so I think you can really cause a shift in the paradigm in treatment and prevent progression of this disease with multidisciplinary approaches and interventions. And quality of life is key. I mean, this is a disease, and most people don't die from Parkinson's now.
Right.
They're going to die from a fall, a cardiovascular event. What do we want to prevent? The fall. And, somebody breaks their hip and you have Parkinson's disease, the trajectory changes drastically, which I'm sure you've seen.
Yeah. I think of the ICF model, the International Classification of Functional Model, that we use so often in rehabilitation. And we look at, the activities right in the middle of the model, and their belief of participation is to the side, the disease or pathology is above it, but then below it is all of the constructual, environmental, personal belief, socioeconomic access to those kind of things. I mean, this is where I'm sure as we dig down, we look at the statistics, those that come from underserved communities are going to have a much faster progression than those that are able to even have time or education or ability to participate in these kind of activities we're talking about. So how do we, get community centers to have activities that basically cost them nothing, to be able to have people come in and do a chair class or a falls prevention class? There was something that you pricked an interest in me, and there was another study, and it had to do with falls prevention by Peggy Roller out of California. And it was a Pilates study, but they were looking at, and she wrote it with a null hypothesis that was very strong, that there will be no significant difference in risk of falls or fear of falls in these individuals. And the inclusion criteria was that they had to have had a serious fall that took them to the emergency room in the last 6 months. That was the inclusion criteria. So we had, broken hips, fractured skulls, busted jaw, busted wrist, that had happened in that previous 6 to 12 months. And what was interesting is after they had done just a Pilates class, this is a reformer class with like 6 people. The teacher was a Pilates teacher, not a physical therapist, not a scientist. She was the intervention. They did it for 12 weeks. And what they found, and what Peggy talks about in her paper, is that every single individual, these 93 subjects, it was a pretty good study, but 93 subjects came completely out of the risk of falls. So they were high risk or severe risk, and they came out of it. And as we were having these discussions, the point that I brought up from this group that we did for the Parkinson support group was a very similar outcome, in that we cannot ignore the impact of socialization, and a positive socialization with people with similar pathologies or similar challenges. And I would love to see us continue to see more research on that, but I think that it's the combination. And even going back, in part of my original dissertation was looking at chronic low back pain. And we found that it were the psychosocial outcome measures that were much more predictive of functional outcome than our physical limitation measures like we typically use in rehabilitation. And it was like, how can I create these positive movement experiences for these individuals that create the desire to come back and do it again in 2 days? Because it's going to be the stickiness of them coming and staying socially with a program or with a therapist or with a trainer that is going to have the longest lasting effects, as you mentioned. And I think a lot of times the being alone with a diagnosis like this is incredibly scary. And I think we've made that point very clear today, is like, please don't be alone with this diagnosis. There are support groups, there are community groups, there's, find it. If you can't find it, make it. It's like that. We know that it's going to make a difference. I wanted to shift gears just a little bit and talk about what are some of the things in the field of neurology that are the advances now being provided. What are some of the interventions, both pharmacological, surgical? What is happening today that you feel is bringing a little more hope, especially for those that have a more severe staging of the Hone and Yar scale, that are more limited?
So great question. And just to comment, again, it's a community, a family approach. I always say, I give people diet recommendations and therapy recommendations daily, maybe 20 times a day. And I always say, the patient can't just do this alone. The whole family needs to do this. And it goes for eating, big, and that's easy. But it also goes for therapies, activities, socialization. There's so much data coming out in the neurodegenerative world, not just Parkinson's, but in Alzheimer's research, mild cognitive impairment research on the socialization aspect of things, and that the community kind of serves as a safety net and kind of pushes you in a direction of prevention of worsening over time. So people who have these good social networks, who have good exercise regimen, or partners in exercise, a good example of that is like the rock steady boxing model, where patients go who have Parkinson's, various stages. They're all there. They're looking at each other. They're motivating each other. They're looking at, he's doing better than I am. He's worse than I am, and people can kind of come together and support each other, and it goes such a long way. I wish there was more programs like that. Here in Miami, we have mostly rock steady boxing. We have a Pilates program as well. We have with St. Augustine University physical therapy. There's a fantastic program for fall prevention, Parkinson's type of of exercises. Speak to and tell my patients about the Power of Parkinson's website very often so that they can get together with family members and see exercises, because sometimes, as we know, even any one of us, if we don't have a clear vision of what we need to do for that day of exercise, sometimes that's the preventing factor that gets you going. And if you do have a good, kind of sequence of exercise, kind of regimens that you'll do 3, 4, 5 days a week, hopefully 6 days a week, you will be much more prone to doing it. So, those things are available. I wish they were even more available, as you mentioned, in every community center around. We're here in Florida. I'm trying to get together because when you say boxing to some of my older female patients, they, kind of aren't into it, although they end up having fun when they go. But salsa and tango seems to get people interested, and we don't have it. It's something that I'm trying to work with some of our community members to try to get a program together, because I think it's an amazing type of exercise that can help also with balance, agility, all the things that promote motor reserve. Another catchphrase that we talk about a lot right now in Parkinson's and in all neurodegenerative disease. So really trying to find the right exercise regimen and right program for the patient, and we're working on that. There was actually an Argentine study looking at tango and falls and also disease progression, and they showed some interesting outcomes where there was much less falls. So echoing what you were saying earlier about that trial. In terms of newer and upcoming treatments, so traditionally we treat symptomatically. This is a condition where it's a progressive neurodegenerative disease leading to dyscontrol or motor control. And what is the underlying pathology is the impairment in dopaminergic signaling or transmission within the brain, and particularly the basal ganglia. So it's a neurodegeneration within the midbrain in an area called the substantia nigra, so leading to a dopamine deficit in the brain. So traditionally our therapies have been add dopamine, so L-Dopa, levodopa. We add medications that can increase the amount of dopamine in the brain, or that increase the amount of circulating dopamine, and that can get to the brain. So we've traditionally been treating the symptoms. And these medications have been around for a very long time and very effective in helping with motor symptoms for a period of time. As time goes on, you need higher doses and different approaches to treatment. You mentioned sometimes you'll cause another movement disorder, which is dyskinesia. Mm-hmm. And not a pleasant part of the illness, and we can get into that. But we've been really looking for disease-modifying therapies, which I think are on the horizon. We have deep brain stimulation as well. I have a very large practice with patients who have been implanted. It sounds, sometimes to patients in early illness like a very aggressive approach, and then it adds to their fear. I usually broach the subject actually early on to just give people hope that if medicine stopped working eventually, we have this option. And it's a fantastic option, and usually reserved for patients who are 5 years plus into the illness, who have continued motor symptoms despite treatment, fluctuations, or are limited by escalation in their medicines by dyskinesias and side effects.
Right.
But a fantastic option. We also, in recent years, have a focused ultrasound, where this is a less invasive procedure where the ultrasound ablation is performed bilaterally, usually on one side and then the other several months later, which was just approved by the FDA, for tremor control. So that's another option for treatment. But as a researcher in the field, we are trying to make our medications for symptom control better. But there's a huge push right now in disease modification across the neurodegenerative diseases. And so we're lucky we have, we're going to be partaking in one of those studies. There are a few ongoing around the world. There's also some interest in the GLP agonists.
I saw that. I was going to bring that up. Recently, I heard something about the GLP.
Yeah. So there was a phase 2 trial that showed less progression in motor disability, recent in 2024. And so there will be, follow-up studies and very interesting, in that field. And even anecdotally, I've seen patients go on GLP for various reasons, and there is some control in tremor. It's not seen across the board. It has not been proven yet in phase 3 data, so I can't speak to it, but there's some signals there.
And there'd been some discussion, I know, for years now, looking at things like Alzheimer's and Parkinson's disease having some kind of relationship with metabolic disorders we'd see in diabetes. So, I mean, it's interesting to me, and I saw that, and I was going to ask you, like, so what have you heard about the GLP influence on Parkinson's? I saw just recently, but also on Alzheimer's. You brought up a couple things, and one in particular, and I guess the take-home message as I'm listening to you is, and I've had patients with the brainstem procedure, and it was a godsend for them. They were able to have, such better function. And we often talk about when somebody starts their first bit of medication that they're in the L-DOPA honeymoon stage. They're going to look really normal. I mean, it's amazing. And for how long? And so the goal is, how do we prevent them from having to have more frequent increases in their medication based on their behavior and manifestations? But I do find that, everything we're talking about is, it's this multifactorial approach that you've been discussing from the very beginning. Is we have the medication that can significantly improve the effect of decreased dopamine interaction, whether it's the receptor or the producer of it in the substantia nigra. But it's like, we don't want to, and this is true with anything, right? When we talk about diabetes, it's the same thing as if we keep putting insulin in, then the pancreas is going to stop doing its function because there's a regulation problem somewhere in our system. And so we want to use as much as necessary, but as little as possible. And so how do we change our lifestyle to be able to increase the time? And everybody's different, but how do we increase the time before our symptoms get bad enough that we would have to increase the medical intervention, the pharmacological intervention? And I think there's comfort, and I use this carefully, there's comfort knowing that there are multiple factors that can influence individuals that have early diagnoses of Parkinson's disease. I want to just sort of bring things to wrap up for today, and I want you to know that I'd love to have you come back and we talk about focal dystonias, we talk about multiple sclerosis, we talk about stroke, we talk about things. So just different topics. And I was also going to tell you that my faculty position right now is at Miami St. Augustine. So that's where I've been teaching. And it's Dr. Miguel Garcia that runs that Rock Steady program there, and Gabriel Somariba that runs the fall prevention program there. And they're doing a phenomenal job. And we also introduced, I'm not there enough to do it, so we're looking for somebody that could also provide the Pilates, but we did a Pilates mat and chair work with the same group that came in for Rock Steady Boxing. And there were people that were, I would say, from stage 1 to 3 on the Yonan-Hars that were actually benefiting and really excited and having a very positive movement experience with the Pilates. So and I had, in the study we did in Coral Gables, we had a number of people that were stage 4, which is quite severe, and they couldn't be in the group class per se, but we had them there during the same time with a one-on-one teacher. And that person had a significant, a positive experience, I'll say, is how we put that. Is there anything that you would love to share, like just talking to your community, when's the right time? What are some things that you'd want to share about Parkinson's disease, and what your role is as a neurologist, and when they should come see you?
Yeah. So firstly, thank you for that positive feedback. And I really try to give as much as I can to our patients. And it's a team effort, obviously, and the community therapists and other physicians taking care of our patients, dietitians, and Pilates is a big one in my world, and it's not just because I'm speaking with you. I recommend Pilates also 20 times a day, in addition to the diet, in addition to conventional therapy and aerobic therapies. And there's so much that we could do for our patients, and unfortunately, we don't always have the time to get into every detail, but we try to educate them early and give them the resources that they can to go and research things themselves as well. We have the luxury nowadays of having fantastic resources and information online, and so I give patients not just medication recommendations, but I would say that's about 15% or 25% of my recommendations for these conditions. And you mentioned something interesting, and in terms of trying to hold off on dose escalation of medication. So a lot of patients do come in early and say, I don't want to take meds because I know that when I start taking the med, then the stopwatch starts. And that's been debunked, and we used, and when I was training, that was a consideration still. We were not sure whether, starting dopaminergic therapies early would lead to advancement of disease, state. I don't believe it, and it's been tested multiple times over and over again, and shown that no, once you start, it has nothing really to do with the disease progression. I mean, that's the individual, the neurodegenerative or the neurodegeneration within the basal ganglia is happening. So how do we stop that? The meds are there for support, symptom control, but the neurodegeneration in one person may be different than another. The cause may be different. Somebody may have a genetic history, and then they have the environment, and they're diabetic, metabolic, cardiovascularly worse off. They have high stress levels, poor sleep quality. There's so many things that I believe end up leading to neurodegeneration.
Multifactorial.
And I think that the progression of the disease is that, and not necessarily at all medication related. What caused it to begin with? Is it a toxic exposure? Did we remove the toxic exposure? All of these neurodegenerative diseases, in my opinion, are probably neuroinflammatory metabolic conditions. So, something's happening systemically that ends up going to the brain and leading to a mismatch between our ability to take care of the neuroinflammation and not. And there's some newer therapies that are going to be focused on like microglial, function in the brain. There was thoughts about, monoclonal antibodies against alpha-synuclein, which the jury's out, but those are being tested. Again, an interesting study starting now that is focused on microglial activation and prevention of progression of illness by modulating our intra-CNS ability to manage inflammation. So those things are happening. The DBS world is a symptom management world, and there's been no data to support thus far, but ongoing, is there a disease-modifying effect of these types of therapies? Now, I think that there is, because if you can keep someone's symptoms at bay, or really control tremor, rigidity, the bradykinesia, which is slowness.
They'll stay more active.
They stay more active, and that leads to disease modification.
Yeah.
We counsel our patients so early now. And when you talk to some good movement disorder neurologists who are seeing these patients every day and have their finger on the pulse, like, they're talking to their patients really early about movement, exercise, keeping muscle mass. I mean, muscle mass is probably, in the longevity world, it seems one of the major factors that will predict longevity. Why is that? If you break your arm, are you more likely to recover and get past it if you're strong and you're fit? Probably. And those factors I counsel patients, like, in 10 years from now or in 5 years from now, if you're strong, you're agile, you've been working on the brain muscle connection.
Yeah. Body awareness.
Yeah, building those pathways, sending the signals through daily, multiple times a day, really building, the dexterity pathways. You mentioned, I think, music, something that complex motor behaviors with music, boxing, salsa, tango, playing tennis. I encourage them to stay playing tennis, as much as they can. Obviously, we want to prevent falls. All of those things, these are the holy grail. Like, they're the disease modifiers that we're looking for. And that'll buy us time until we do find something that can slow down neuroinflammation.
Yeah, I'm so glad you said that, and I stand corrected on that, and I'm glad I stand corrected on the dosing progression. And again, it makes sense to me. The more active you stay, this is just like what I was talking about. If you are having successful movement experiences, you're more likely to keep having movement experiences. It's when you stop having movement experiences that progression of disease and dysfunction progress. One of the things that I had pulled up too, Dr. Lerman, was looking at, again, we know the damage that any kind of inflammatory response does. We know that inflammation is, the culprit for a lot of our diseases today. It was, like you were talking about, something called Dapensutril or something like that was looking at some early studies for anti-inflammatory therapies for Parkinson's and other neurological challenges. I find that interesting as well, because part of this too, I know with, you probably know Dr. Olga Kromo, rheumatologist, pretty close to you. And Olga is very much into integrative medicine as well as the rheumatology. But it's like looking at, and of course, she's always dealing with inflammatory disorders because that is her niche. And how do we, in our diet, in our stress life, there's so many other factors that can influence the increase or reduction of inflammation. So I love that that's being part of the discussion now without a doubt. I know it is with multiple sclerosis and other autoimmune diseases, but really controlling that inflammatory response. I'm looking forward to it. I can't wait to hear the research on that over the next 5-10 years.
Yeah. And I mean, one of the, and I'm sure you see this in your world as well, something, taking the pill or the infusion or the treatment, it's a lot easier than putting in the work to do the daily, to motivate yourself to daily activity and the getting out to the Pilates and, getting in the car and going to the rock steady boxing. And we try our best to motivate. And I use backup data to try to motivate patients, like, hey, in both Parkinson's and Alzheimer's, like, here's this medicine may be helpful, but that's one little slice in the paradigm of the pie that we need to pursue here. The other parts are, diet, sleep, exercise, and keeping yourself aerobically strong, making sure your vascular risk factors are well controlled. Homocysteine levels are predictive of longevity. So inflammation within in the body. I think the rheumatologists and neurologists this is all inflammatory. These conditions. And genes play some role, but our diets, our sedentary lifestyle. So I wish there was, and you could speak to this, like I look for ways to motivate patients to drink the medicine of exercise
Movement
and lifestyle. And it's not always easy.
Well, we can finish up with what Joseph Pilates considered the formula for healthy body and happiness. And number 1 was, of course, movement and exercise. Number 2 was nutrition and diet. Number 3 was sleep hygiene. Number 4 was hygiene. And I always twist that to be mental hygiene. Like, how do we get rid of all the negativity and the running thoughts and, third year medical students' disease in our head when we go into Dr. Google and get too much information and persever on it. And then he goes into plenty of fresh air, sunshine, and a balance of life stressors with work, play, and rest. And so I love that formula. That was around in the 40s and 50s. I'm sure it came from his yogic studies. But the idea of this is the lifestyle that we have to create it. It's not normal. We look at our children and an article or a book that just came out about anxious generation of psychologist out of NYU looking at Gen Z and just saying that their risk of suicidal ideation is up 400% in young women compared to the millennials. And what was interesting was that, of course, is tragic, but the best intervention he showed over and over again was deconstructed play. Like, you have to be able to go out and be creative. You have to move. You got to climb a tree. You have to be outdoors in the sunshine. You listen to Andrew Huberman get on his soapbox about getting some light in the morning, and some of the people there with, heavy exercise every day. I do think collectively as a society, the message is getting out that, sedentaryism is the new smoking, and we need to get outside. We need to move. We need to go walking. We don't have to do really strenuous activities. Most of the research, that's why I was sort of surprised on the HIIT training that somebody was doing. But most of us, we just need to go for a walk and, get in, a good amount of steps every day, and maybe have a vigorous exercise 3 or 4 times a week. And Joseph Pilates also, with his contrology exercise, that was the mat work, Andrew, that was just these 30, 40 exercises that you would do as a sequence every morning or every day. And his promise, this is back in the 40s, was if you did my contrology exercises 4 to 5 days a week at home, there'd be no reason to have hospitals, insane asylums, or prisons. So you can take that prophecy and figure out what to do with it. But what I love about it is people that are active, people that are present, really do have, a much better chance of being healthy physically, mentally, spiritually. I also am very impressed with, when people come out from a Pilates or a yoga or a Tai Chi class or a run, they're not going to be in a violent or an angry or, anything that would threaten, an unethical situation. It's amazing that, the peace that comes into us when we are physically active and move the way we're supposed to move as human animals is amazing. So,
yeah, and to give the listeners some just nerdy science background on that is that, in Parkinson's and in society right now, it's you mentioned the Gen Zs and social media and the doom scrolling and the exercise, the movement, walking out of the Pilates class, the aerobic exercise. You're tapping into dopamine, and probably some of these measures and these trials that we see in preventing progression or even disease prevention with people who exercise in a preclinical, premorbid state are related to us tapping into our own dopamine systems. And is there a disease modifying effect? For sure. I mean, when you break down muscle, there's neurotrophic factors go to the brain, tells the brain to not to degenerate, and there's anti-inflammatory effects within the brain. It's being tested and shown now. We're still in its infancy because we just don't have a lot of ways to measure inflammation in the brain, but we're getting more sophisticated. But just tapping into an exercise, walking, increasing dopamine, increasing norepinephrine, it helps with your movements, it helps with your mood, anxiety levels, all of that pays forward to you getting up the next day and doing it all over again. And so it's once you get on that hamster wheel, you don't get off of it. And when you have to, let's say I have a patient who has a knee injury and she is early 58 years old. She was exercising every day, doing everything we tell her, a great star patient, boxing, dancing, going to the gym. And then she hurt her knee, and then she noticed the change in her Parkinson's control immediately. And then now fixed the knee back on the hamster, and she's now better. And so just the intervention alone could help. I think it's probably increasing the neurotransmitters, just tapping into our own reserves. We spoke about Huberman getting that light in your eyes in the morning. It probably increases the dopamine and the good chemicals in our brains.
That is, by the way, his favorite neurotransmitter is dopamine.
Dopamine. Most people, and dopamine is a is a neurotransmitter that drives us, that
Yeah.
motivates us. So there's a lot to it. And in Parkinson's, we spoke about the non-motor symptoms before briefly, but in Parkinson's, certainly something we talk about now is that lack of motivation, the fatigue, the reward center of the brain is deficient, and and it leads to a vicious cycle. And some people can overcome it, as you said. The community can help, families can help, patients who have motivated units that help them do better, hands down. The science, we're working on it. We have a long ways to go in terms of cure and disease prevention, but there's hope. I see studies coming across my desk all the time now that are focused on disease modification and not just symptom control. And then, also optimization of the medicines that we already have mechanistically. But in the information age, I think, and the access, we don't always need to go somewhere to get these types of pieces of information. We could do it at home, like what I mentioned earlier with the power of Parkinson's. Like a lot of my patients, their family works. They can't drive really very far. So how do we create a situation for them where they can do stuff at home? You mentioned the mat, the Pilates mat, regimen. I think I'm going to have to go and look into that further and maybe come up with something to give my patients to start doing at home because they need it.
Yeah.
I'm a big, I love Pilates. I think, core and balance and all the muscles that you work on. I always tell my patients in general, but Parkinson's patients particularly, like, you're looking in the mirror, you see any muscle you see, or any muscle you don't see in the mirror, you should be working out that muscle 3 times as much as you do the ones that you see. Because that's what keeps you upright, and that's what keeps you walking, and that's what gets you off the floor. And Pilates is just a great tool for that. In addition, again, to the aerobic and the strength training. But I think a message to our patients is that there's hope. People live 30, 40 years with this disease now and can live good quality life. People do not, for the most part, die from Parkinson's, and usually it's something else. But quality of life, and we talk quantity and quality, and that's, quality is super important. And the way we can do it, and together with a good physician, good family network, good community support, this is something that you could keep at bay and live well with for many, many years.
Yeah. Dr. Lerman, thank you so much. I think that we hit all of the objectives of the Live Aligned podcast of providing good information, providing some hope, and removing fear. And I think that the biggest takeaway is that it's multifactorial, and the quality of our lives, the ability we have to be active in the things that we can control and work with good medicine and good healthcare providers for the things that maybe we can't control, and and keep the hope in this, and be able to have a good quality of life, taking away that our activity, our movement, our motion, these are some of the most powerful tools that we have for our health. And I know sometimes it seems daunting, especially, I can't imagine what it feels like to be suffering from Parkinson's disease and the lack of motivation. But I know that those that have forced themselves to get up and to go do something have a much better quality of life. And in that, we can maybe finish with that. And just again, thank you so much for your wisdom, Dr. Lerman. And we appreciate you, and we'll see you in the future.
Great. Thanks for having me. I really appreciate it. Thanks for the kind words.
You bet. Thank you for joining the Live Aligned podcast. If you like what you hear, please let us know by leaving a review on your favorite platform. If you have comments or questions, please leave me a message at drbrentanderson.com. You can follow me on Instagram at drbrentpt. To take a deeper dive into the science of movement, check out my new book, Principles of Movement, available on Amazon. Live Aligned podcast is produced and edited by Gabe Anderson. Music and sound designed by Delver. Special thanks to my team, Elizabeth Jimenez, Melissa Pereda, Cesar Maya, Gary Bentz, and Charlie Zuckerman. I also want to thank the team at Polestar Pilates for sponsoring and supporting us with technology, marketing, strategy, and much, much more. Thanks again for listening. Live aligned and be kind.